I want to talk a little bit about functional medicine and nutrition as it relates to running. And I thought it would make sense to start with a story that was kind of the intersection of these things in my own life. When I was 6 months pregnant with my first daughter, I had gone to Angel Island to go out on a hike with some friends. I was going to do just a day hike with them, and they were planning on camping there for the night. And as I started heading down the trail, which is, you could barely see it kind of winding through the green trees here. As I started heading down this trail, I saw that the ferry that I was supposed to be on was doing their last call, and I'm still about a half a mile out. And I had been a runner before I was pregnant and had paused it for the majority of my first trimester because I had a lot of nausea and sickness. And so when I heard that ferry horn, I really questioned, do I want to stay on the island for 2.5 more hours? Because the ferries are pretty far apart. Or if I am going to make this, I'm going to need to run. And I had just kind of started in my second trimester to pick it back up. And as I was wrapping up the second trimester, I wasn't sure it was going to go well. So I knew that if I missed this one, I wasn't going to enjoy hanging out. So I started to run. And about 250 yards out, I could see them starting to close things up. So I dug really deep and I picked up the pace and I yelled as loudly as I could, "Wait!" And the ferry agent, who was clearly used to last minute people trying to get on the boat, just kept closing up. And somebody that was on the balcony of the boat, there were many people witnessing this humbling moment of me running pregnant to catch the ferry. Someone yelled out from up above down to the ferryman, "She's pregnant, wait for her." And I could see as I was running up, I could see the ferry agent took pity on me. And with the entire upper deck of the boat watching and waiting, I jogged the rest of the way at a very controlled pace until I could get onto the boat. And very kindly, the passengers clapped for me as I got onto the boat. So when I was thinking about running and pregnancy and kind of my own experience, which I'll trickle in throughout this talk, I thought this was sort of just a salient moment of really the adjustment and the humility that comes with how you think about yourself as an athlete prior to this acute, 9.5 month change to the live adjustments that you really have to make throughout the experience of staying athletic in a pregnancy. And now in my career as a nutritionist, my job is to help people navigate their health challenges. And that is whether it's related to illness or symptoms or physical performance or mental health or well-being. And I do that broadly through the lens of food. And a big tenet of my practice as a functional medicine nutritionist is to make sure that my clients, or in this case, my audience, know what they're doing and why they're doing it. So I like to start my talks by saying there's not a single right way to do anything as it relates to nutrition or movement. There's not a right way to train. There's not a right way to eat. There's just optimal ways depending on what your goals are and what your body needs. And when it comes to pregnancy, what works is deeply personal. Pregnancy amplifies individual differences, which is so neat and also very humbling. And that is very much the lens of functional medicine, is looking at the whole person, including the changing physiology, changing symptoms, changing environments, and priorities for the pregnancy. So I wanted to frame running during pregnancy with both the benefits and the realities, because I think we'd be remiss not to focus on yes, there are some really great things, but also there are things that are more difficult to navigate for a woman going through this acute change. On the benefit side, the evidence is pretty consistent. Continuing to run when it feels good and when it's adapted appropriately supports cardiovascular fitness, supports aerobic capacity. And maybe not surprisingly, it has very real benefits for a woman's mood, her stress regulation, her sleep, all of which, as you can imagine, struggle for many women during and throughout the pregnancy. And at the same time, there are physiological shifts that change how running feels. The most common shift is perceived effort. And I'm going to talk kind of throughout this talk about rate of perceived exertion or perceived effort, because specific to running, it really, the RPE increases at what was previously a familiar pace. And so, along with that, that RPE change really affects the heat tolerance, the hydration needs, and many other aspects, load that are changing throughout pregnancy. That can make running feel harder sooner, especially if you're in like a warm training environment. So, when I work with pregnant clients, the goal for us isn't to chase the same training metrics from before they were pregnant. It's really to understand the individual needs of their body and to train with, the physicality or the nutrition in a way that's supporting both their pregnancy and their performance goals. And so I thought it would be helpful to talk a little bit about what some of these component pieces are when we're discussing sort of this acute period and performance and nutrition. So I think it helps to start talking about what's changing in the body, because most of the differences people notice aren't about fitness disappearing. It's about the physiology that's shifting. And one of those pieces is blood volume. Blood volume increases by up to 50% during pregnancy, which I think a lot of women know, and maybe their partners know, like you have an increased blood volume when you're pregnant, but 50%, that is a lot. And it peaks in the late second trimester. And even with this expansion of blood volume, oxygen delivery per a woman's heartbeat is, regardless of those changes, still slightly diluted. So your heart rate is actually starting at a slightly higher beat per minute, and blood flow is shared with both the pregnancy demands and the running requirements. So this is one of the reasons why that familiar pace might feel a little harder. Not surprisingly, there's also musculoskeletal and joint mechanics that are changing throughout pregnancy. You may have heard about the hormone relaxin. I think this is one of probably the most touted changes for females when they're, initially meeting with their PCP or talking about some of the ligament sensations they're having. Relaxin is a hormone which is actually produced in men and women in small amounts. But during pregnancy, that production is dramatically increased. Mostly it's starting the dramatic increase in the first trimester, but it actually is going to increase all the way through the second trimester. And the relaxin increases the connective tissue laxity, which can really subtly reduce the joint stability. And so just thinking kind of about your own joint mechanics, if you're pregnant, if you're expecting, if you're already pregnant and you're running and you're noticing like, oh, my ankles feel different or my knees feel different, or like I'm doing kind of the same thing, but it feels different. Part of this is like your hormonal profile has changed and thus your connective tissue is changing. And that subtle change can really alter load distribution. Logically, it would follow that this would also alter like the gait of your run and some of the biomechanical load. I'll talk a little bit more about that in a minute. And in my opinion, the third one is one of the most interesting ones. This is thermoregulation. Because the body is supporting the energy demands of that fetal growth and the placental function, there are increased cardiovascular and respiratory work that is happening. And in pregnancy, metabolism and fuel needs shift as well. Specifically, carbohydrate needs increase and blood sugar dips can feel a bit more intense. And so a lot of the times I'll have clients who are sort of, pre-pregnancy figuring out what it looks like to eat consistently or to maintain blood sugar stability. And those gaps or those desires to really kind of figure that out can become highlighted in pregnancy when the demand increases. So I see this even more so in pregnant athletes of any level, really, when it shows up as underfueling, because the underfueling repercussions tend to become a bit more exacerbated in pregnancy. Sometimes that takes the shape of fatigue or nausea or extreme nausea or feeling particularly wiped out after a run. So recovery is this other piece that we're going to talk a little bit about too. And then finally, as I mentioned, there's RPE. This is rate of perceived exertion. There's a very formal scale, which the Borg scale, which is really a 6 to 20 scale. In a more clinical setting, you might see people using that. I think that the 0 or 1 to 10 scale is a bit more applicable. So I'll actually, on the later slide, I have a picture for reference for those watching this, if you'd like to sort of adapt that RPE scale into your own training. And because of all of these changes that are happening at once, you might be used to externally measuring progress with your Garmin or your Fitbit or your Strava app. And during pregnancy, I think it can be much more helpful to sort of tune back in with this internal sense of effort as a more reliable guide than looking at pace or heart rate alone. I mentioned earlier that during pregnancy, volume of your blood is increasing up to 50%. It's a huge change. Because of that, your resting heart rate is increasing as well. And often we're seeing that by 10 to 20 beats per minute. And just to think about this for a second, if your resting heart rate is 70 beats per minute and you're pregnant and now your resting heart rate is 90 beats per minute, well, for you, 90 beats per minute might have been like a walking pace. So now at rest, your heart rate is starting from the beats that maybe you were starting from in a walking pace. So you can kind of just think about how much that 10 to 20 beat starting period might influence the way that a workout feels. When you're starting a run, you're starting from a higher baseline than you were pre-pregnancy. So it follows that the amount of blood that your heart pumps with each beat is increased, which is actually a very effective and efficient adaptation. Later in the pregnancy, this rate tends to be one of the main ways that your body meets the increased demand. So it's actually, while it might feel frustrating or uncomfortable, it's a pretty impressive adaptation that your body is making to being pregnant. All of this means that the oxygen cost of running increases. You're essentially, paying a bit more to get the oxygen. You're not suddenly less fit. I hear that all the time from pregnant clients, that they feel less fit, and that makes sense sensationally. But objectively, that's not what's happening. Running simply requires more oxygen than it did before because of the increased blood volume. So practically speaking, and even for a well-trained athlete, this potentially means being out of breath sooner or being earlier to fatigue in a workout. And this is where I really want to normalize something important. These changes are expected. When I have worked with professional athletes or semi-professional athletes, this is something that all of those athletes, if they become pregnant, have gone through to some degree, and it reflects a healthy cardiovascular adaptation to pregnancy, not a loss of fitness. This slide really, I think of as the cornerstone to how I think about running during pregnancy. That perceived exertion basically is how hard the effort feels in your body. And during pregnancy, RPE becomes more useful than pace or heart rate or the splits on your Garmin, because one of the things that's happening is that VO2 max isn't static in pregnancy. And sometimes my clients have come to me with a very clear sense of what their VO2 max is, and sometimes clients have never even heard of this term. So it's not necessarily important that you have some measurement of this, but the body's aerobic capacity doesn't shrink in pregnancy. It's sharing oxygen with more systems. And if you think about that, it makes sense, because now there's the presence of a fetus or the placenta, and these are both two new systems that are requiring that blood and aerobic fuel. So the aerobic system is supporting more total demand across more tissues at baseline. Again, kind of going back to this baseline is starting from a slight elevation. And because of that, pace-based training becomes slightly less reliable. For a non-pregnant person, 2 runs can feel different week to week, right? Like if you think about, you ran on Monday and you're training for something in 3 months, and then you go out on a run on Thursday and you're like, oh man, I'm really not feeling it today. Like that's a very real experience that any athlete I work with might talk to me about. In pregnancy, the same pace can feel completely different day to day or week to week, based on the trimester you're in, the very real and acute changes that your body is going through, the amount of sleep that you have or haven't gotten because of your changing body, hydration, fueling, temperature. So this is where RPE, your internal clock and gauge of how hard you're working becomes a very useful tool. It automatically, by using RPE, it automatically integrates everything your body is dealing with. Cardiovascular load, breathing, the heat, the fatigue, how much you have or have not been able to recover. It's real-time feedback, and that adjusts as the pregnancy progresses. And what I find, just anecdotally, I'll offer that sometimes the work isn't having an athlete continue to train in pregnancy. I know that that is initially a concern for many women, but to be honest, a lot of the conversations I'll have with clients who are going through this, fitness journey through gestation, the conversation is much more about managing the shift that they have to go through from being able to look at their watch and say, this is how I did it, and then that's how I know I succeeded, to kind of relying on trust and intuition. It's a big shift for a lot of women. So I encourage clients to ask, what does a sustainable effort feel like today when you're running throughout your pregnancy? And just practicing sort of whatever version of that question to gauge your RPE is to help you feel like you're in tune with your own physiology. Okay, let's talk biomechanics. I know I said something else was my favorite topic, but this actually might be my favorite thing to talk about. I mentioned earlier that relaxin is a hormone produced by both men and women, small amounts when non-pregnant, and in pregnancy, the ovaries produce a lot more during that first trimester. I mean, the word does such a cool job. It's not onomatopoeia, but it's something in that house of it's relaxing. So that's really what it's doing. It's helping to prepare your body physiologically for labor. And in the first trimester, the ovaries are producing a lot of it, and then the placenta is producing more of it later in the pregnancy. Both of those are helping to soften that connective tissue so that the body is prepared for birth. And relaxin does not act in one specific area. It's not dosed or sent to just your pelvic region in preparation. It affects the ligaments throughout your entire body. And that can make those joints feel a little less stable because they're relying more on muscular control in the presence of relaxin. A parallel I would draw here is if you yourself are hypermobile or you have or know somebody that's hypermobile, you know that this sometimes it means that you can't be training to end range of motion. You have to be a little bit more thoughtful about the range and how you're cueing somebody to make sure that they're not overstretching or overmobilizing. And in pregnancy, I think there's a real similarity here. You have to be a bit more thoughtful about those end ranges in motion. And in the case of pregnancy, there's limited research on the exact mechanism of the increased relaxin. We don't have a lot of really thorough studies on pregnant women, period, and certainly not for some of these more specific niches of it. But in non-pregnant women, there is research linking relaxin peaks during the menstrual cycle, during the luteal phase of the menstrual cycle, to changes in that anterior cruciate ligament, that ACL ligament in your knee. And in that phase of menstruation with the higher presence of that hormone relaxin, the same as we're talking about in pregnancy, but in a non-pregnant person, that peak during menstruation creates a higher tissue and higher incidence of non-contact ACL injuries. So just kind of thinking about this for a minute. Lots of relaxin, more potential for an ACL non-contact injury. So it follows that the changing biomechanics, the load distribution, the softening of the connective tissue would demand that more attention be paid to these higher risk joint moments like knees, ankles, spine position. And so when we talk about pre-pregnancy and then pregnancy and working out, sometimes I think, the guidance, and I'll talk in a minute about how guidance has changed, but it used to be if you aren't active before pregnancy, don't start being active during pregnancy. That's an antiquated opinion these days. There are a lot of things you can do, not the least of which is paying attention to the biomechanic kind of positioning. So sometimes it's really empowering for a newly pregnant woman to work with a trainer, work with somebody on biomechanics, because this can be a really compelling time to adjust body position. Secondly, the center of mass, maybe kind of obviously here in pregnancy, starts to shift forward and upward as pregnancy progresses. Even subtle shifts, sometimes early in the pregnancy before a woman feels like she's more visibly showing. Even those subtle changes can alter posture or stride length, and that will change how the force is absorbed with each step, how that force is absorbed through the feet, through the knees, through the hips, right up that keychain. And in my work with pregnant clients, this is where extra attention to glute activation and supportive cross training becomes especially important. So, are we setting your body up for success? Are we functionally training for your sport? And in the case of running, because it's a high impact sport, that means creating a little bit more activation in that big glute and hip region prior to a run. Third, there's an increased load on the pelvic floor. You can understand why. Also on the abdominal wall, you can understand why, especially in the third trimester. So, given the nature of the high impact activity that running is, over time, this added load can present as pelvic pressure, and sometimes that means gestational incontinence. So, depending on the client's healthcare, I really encourage, because one thing I hear from a lot of pregnant clients and postpartum clients, even for years postpartum, is that incontinence, exercise-induced incontinence or gestationally induced incontinence, is so frustrating and humbling and disallows them from practicing their sport. So when I'm working with clients, it can be very meaningful to give a good referral out to a pelvic floor therapist, because through your healthcare, you might be able to get those sessions for free, or if not, you can find somebody outside of your healthcare to really address the ongoing pain or the leaking, if you're leaking when running during pregnancy or postpartum. Again, I was sort of like thinking about what came up for me as just, if I were a layman or if I were my audience. And this was one of the things that like immediately popped into my head. It was Alicia Montano, who in 2014 ran the 800 meter at the US championships while she was 34 weeks pregnant. It's worth a watch. It's a great clip. It's a great clip for a lot of reasons, but also it was like, 12 years ago, and the society had not quite really got on board with like, it's okay to work out when pregnant at a high level. And she does such a good job in this news clip of sort of just conveying how empowered she felt doing so. It's also just like, how can you not tear up watching? She came in last place, by the way, and she was just so delighted that she was there doing it. It was really an amazing story. When you watch this, and I thought maybe this picture could sort of do this justice, each step you take as a runner, this is true for non-pregnant runners too, certainly more important when you're pregnant. Each step of a run is a single leg balance exercise. And this is why I think unilateral training is so important and really addressing some of the movement compensations, because in a run, you're doing that 100, 200, 1,000, 5,000 times, depending on the length of your run. Pregnancy requires recalibration to training throughout the pregnancy. And as mass shifts into that forward and upward, there's more demand for coordination from the hips, the core, the pelvic floor. And so if and when that coordination lags, the impact can be felt harder. Again, oftentimes things are exacerbated during that gestational period. Pelvic girdle pain, sacroiliac or SI joint irritation, those are both common during pregnancy, particularly as the pelvis is adapting to the changes in load and stability. Downhill training and speed work often feel harder. I hear that a lot from my clients, both because the increased impact forces from a downhill run, they require more control during landing, which can feel less comfortable as balance and those joint mechanics change. So for this, small adaptations can be really supportive, shortening the stride, reducing intensity, terrain variability. If you're a trail runner, consider running on flats where there's a little bit less variable in the ground or in the terrain, and maybe building in some more frequent recovery days. And I included falling here because I work with trail runners and ultra runners. And, when you're pregnant, any PCP, any primary care provider will tell you the number one concern is falling. And so we're really trying to minimize risks in logical ways and take low stakes out on for your runs. So that's why flat trails or even tracks like this can be thoughtful places to train. I love this topic. Thermoregulation is so interesting. Basic metabolic rate during pregnancy. We've talked about blood volume increasing. We've talked about your heart rate increasing. That means that your basic metabolic rate, the amount of calories that you're burning at rest, if you didn't do a single thing all day and you just laid still, the amount of calories your body would be burning in that at rest period in pregnancy is increasing up to 20% by the third trimester. That means your body is producing more heat at rest before an exercise even begins. Running generates a lot of internal heat. And during pregnancy, heat dissipation becomes less efficient because blood flow is preferentially being directed to the uterus and to the skin. So your sweat response in pregnancy is often altered. And the bottom line here is your body may not be able to cool itself as effectively as it did pre-pregnancy, especially considering your training environment. And so there's already some nuanced research coming out about non-pregnant women and how we train in different environments, whether hot or cold, like ice baths. We don't need it to be as cold as our male counterparts to reap some of the same rewards. And similarly, thinking about pregnancy, it might not be as effective to train in a heated environment for a lot of the aforementioned reasons. It would follow also then because of the increased potential environment and your increased metabolic rate that your fluid needs would be increased because of that higher blood volume and potential for sweat loss. So dehydration in pregnant clients is also, I think, one of my top 5 things that I'm looking at to make sure that they're replenishing logically. The supportive approach here to these changes is generally a proactive one. Know what's on the horizon. Have a sense of what your training environment is before you get out into it. You don't want to be caught unaware on a long, warm, humid run without proper fluid replenishment or electrolytes if you need it. So consider choosing a cooler day to train if it's a warmer season, slowing the pace if it is warm outside, making sure you're prioritizing hydration and potentially electrolytes. And always going back to that RPE piece of listening to your body and doing the live reaction of adjusting if necessary. So we've covered some of the elements of this. I want to geek out for just 1 second. Thirst is regulated by the brain through osmoreceptors in the hypothalamus. During pregnancy, the threshold for thirst, an antidiuretic hormone, released shifts to a lower blood concentration because more blood volume, meaning you may need more fluid before you actually feel thirsty, especially when you're doing aerobic exercise like running and the sweat that might produce. And because pregnancy amplifies things, dehydration and even mild dehydration is not ideal. So an added layer to pregnant runners, and when I'm working with them, is to pre-hydrate before a run. Sometimes if it's a race, means pre-hydrating, in the 48 hours leading up to it, just like you would with carb loading, rather than trying to catch up mid-run. And for longer runs or hotter conditions or higher sweat rates, electrolytes, thoughtfully curated electrolytes can be helpful with fluid retention and circulation, not just the hydration replenishment. Okay, I'm going to take just a little note on each trimester here from a fueling standpoint, nutrition standpoint. The first trimester is often the hardest for my clients and for many women to fuel, maybe especially for runners who are adjusting to the acute changes that their body is going through and their training routine has been impacted. Nausea, food aversions are super common in this trimester. So the goal here isn't like perfectly balanced meals. It's often keeping blood sugar steady and getting whatever food in that you can hold down and that you feel good about. That often means more small, frequent, carbohydrate-forward meals because they tend to be more tolerated, and that can actually help to reduce nausea. And when I'm working with people, this becomes a very personalized thing, like, week to week, can we prepare the kind of foods that might sound good, or can we have just lots of options so that when 75% of it sounds bad, you have something still available to you. Fatigue in the first trimester is real, sometimes profound. For athletic women, this can be a hard transition. Inconsistent eating, maybe because of nausea and those food aversions, can add to that fatigue. So my work in these months is often focused on validating the client's experience. It's real, and helping her tolerate the acute changes with some personalized strategies. I'll share one from my own pregnancies, keeping crackers on the bedside so that I had something to eat right when I woke up. And I, maintained a level of fitness throughout both my pregnancies. And I credit some of that to just like the 1980s soda crackers that our nurse in elementary school used to hand out. That was like my go-to. Yeah, the long overnight non-eating window really produced nausea for me in those early morning hours. For those without severe first trimester symptoms, training may continue like largely as usual. In that case, the real work can be developing the skill of fine-tuning that rate of perceived exertion in a time where you kind of feel yourself still, so that when the adjustments need to be made in the second and third trimester or postpartum, you've already practiced the ability to really tune in with your body. Second trimester, this is when people, if they felt sick in the first trimester, maybe start to feel more like themselves again. Energy levels improve, nausea might ease. From a nutrition standpoint, the demands in this trimester are actually increasing. So it's not a huge jump, but it does matter for runners because eating regularly and supporting the training tolerance and recovery, even if the appetite feels normal and workouts feel easier again, is still really key. And the nutrients and minerals here worth discussing are carbs, protein, and iron. If I had a longer talk, I would probably add a bunch of other things into there, sometimes covered in the prenatal vitamin, oftentimes not covered. So, always work with your OB and your PCP to look at the lab work that you have and respond accordingly. Aerobic and endurance training relies heavily on glycogen, and glycogen is the stored form of carbohydrate. So underfueling tends to show up for clients who are running, or if you're running a lot in your pregnancy, underfueling tends to show up as stalled endurance or higher rate of perceived exertion, poor recovery, or any combination of these things. Protein comes up a lot with pregnant and non-pregnant clients. It's been a really hot topic over this last year, over this last week even. Broadly, I just want to offer that like protein needs rise in pregnancy. I've done some writing about protein and sort of why it's still a point of contention 85 years after our guidelines were determined. Generally speaking, I'm recommending like consistent intake across the day as a focus rather than, really high protein goals in any one meal. The trend of increased need during pregnancy continues in the case of iron as well. Demands for iron-rich food significantly increase in the second trimester. That is why I put this picture on this presentation. The expansion of blood volume, the increased fetal needs for iron, the placental growth. If you are an endurance athlete, you are already at higher risk because of sweat loss and because of something called foot strike anemia. I think that's the colloquial term, but when your heel is consistently hitting the ground, it can add to anemia, specific kind of anemia. Pre-pregnancy menstruation loss. So if you continue to train in pregnancy, iron is one of the things to prioritize paying attention to. Low iron is one of the most well-documented nutrition performance links that we see in pregnant athletes. So this might mean prioritizing iron-rich foods, pairing them with vitamin C to help with absorption, or a lot of people know that one. Not as many people know that you need to avoid taking your iron with calcium or avoid taking your iron with coffee or tea because it inhibits the absorption of the iron. And as always, please, please, please pay attention to your labs. If you see all greens, like take a second look at it. Sometimes, especially in conventional labs, if you're like one data point away from being anemic, but you're still in the green, they'll say you're fine. You might notice that you don't feel fine, and that's important to pay attention to. This is me on my last day of my third trimester. I did not know I would be going into labor that night when I took this picture. I was at the gym getting what would be my last workout for a few weeks. The third trimester is when the gap between what your body needs and what it comfortably tolerates tends to widen. From a nutrition standpoint, energy needs are really at their highest here, but the stomach capacity is reduced. Digestion and gut motility are reduced. So the onset of fatigue tends to happen a bit more quickly in this trimester because it's really hard to sort of thread the needle on everything unless you have a lot of time to commit to, meal prepping and, the kind of external support that makes these things easier. Mechanical load is at its highest in pregnancy. Sleep is often affected because of the size of the baby. and all the other changes that have happened to your body. So sometimes that also means that recovery and the capacity for recovery are reduced. Studies are consistently showing that exercise tolerance is decreased in the third trimester. So again, even in well-trained athletes. So whether you're an everyday athlete or a professional athlete, my experience is that in this trimester, things are affected. So sometimes I like to say to clients, like, how can you think of yourself like water and just move past this obstacle in a way that feels realistic for you? Doesn't have to be perfect. It's progress, not perfection. Protein earlier in the day, smaller meals, more frequent meals, listening to the RPE pieces, all can really help here. I wanted to get a slide in here that talked about like what we know as evidence-informed, evidence-based guidelines. And I included that RPE scale that I mentioned here. And I just wanted a kind of a summary slide to offer you, as I like too long didn't read. Like basically the gist of this is like listening to yourself. Intensity should be viewed in the context of your overall training profile. And so that might mean that you are focused more on being adaptable rather than, perfectly consistent, especially as compared to what you might have been doing pre-pregnancy. Oh, and then I took us through a few slides of just generally what we know. We know that pregnancy alters our metabolism and it changes our needs for fuel. A lot of the times, like I'll work with clients who were just figuring things out in their pre-pregnancy journey. And so they can continue to do that, like right after a workout, prioritizing carbohydrates pre and post a workout, especially when you're running for longer distances. Again, glycogen storage needs are increased during pregnancy. So those good complex carbs are really important. We know maternal protein requirements are higher. Here's that range that I mentioned. This is a pretty big gap actually between these two, but this also might be very different depending on a lot of variables that could be true for you individually. So take it with a grain of salt. And then we know that iron status influences recovery and training tolerance. I really wanted to hit this point home with a visual of this is what a normal amount of blood cells would look like. And when anemic, you have less blood cells delivering less oxygen. And so it follows that there would be symptoms, including exercise intolerance. So that's really important for athletes and runners in pregnancy. Supplementation. This is a huge question I always get because I have a lot of clients that are referred to me from functional medicine doctors. And so often one of the first questions is, what can I keep taking? What should I stop taking? And in so many ways, pregnancy, it's still in the United States has a abstinence only approach because there's a lot we don't know, because there's a lot of research that we don't have on pregnant women. So targeted supplementation when needs are known or likely, if you are living in a darker area, if you can't get outside, like, vitamin D tends to be one of the ones that are lower and might require supplementation. Iron is another example. Obviously a prenatal that has a really quality folate in it, which is B9, avoiding unnecessary or high dose supplements, or unless that's something you've discussed with your doctor. And, just making individualized decisions based on your own risk profile, your age, your labs, your dietary habits. I work with a lot of plant-based athletes, so kind of just figuring that piece of the puzzle out with their B profile, for example. And then what we don't know. This slide reflects how guidance around exercise intensity in pregnancy has evolved as research has improved. We still have a long way to go. Evidence is pretty consistent that moderate intensity aerobic exercise is safe for most uncomplicated pregnancies. And this is supported across sports medicine and obstetrics, and in the literature is generally now the baseline recommendation, not a special exception. Secondly, vigorous exercise can be appropriate for an experienced athlete. And vigorous can, it's a pretty subjective word. So just thinking about what might be right and feel safe for you. Falling is the main risk you want to avoid in the case of, like a trail runner. If you were training at a higher intensity before the pregnancies and you're having an uncomplicated pregnancy, continuing high effort work can be appropriate when it's guided by symptoms and tolerance and obviously buy-in from your primary care, your OB. So you'll notice what we're not talking about here are pace targets or heart rate zones, because RPE is more reliable than those things during pregnancy. Cardiovascular changes make those external metrics less predictable. Perceived effort reflects what your body's actually handling in real time. And another point that I've sort of, touched on is that tolerance changes week to week. So this isn't a failure of your discipline or your hard work, it's physiology. Sleep, heat, hydration, fueling, mechanical load all influence how hard a given run feels in that gestational period. Intensity shouldn't be viewed in isolation, so just contextualize how hard you're working and what feels right for your body, depending on how you're able to recover or how frequently you're working out. And I think on this slide, it's also worth naming what we don't rely on anymore. Older guidelines used fixed heart rate caps, like the one that I heard a lot, not so much these days, but was like, don't go over 135 or 130 beats per minute when you're pregnant. I'm not even sure where that guidance came from, to be honest. But 10 years ago, I heard that a lot. And nowadays I hear it less, but I still hear it. That's antiquated, archaic advice. It might be given in specific instances. So if your doctor is offering advice like that, it's okay to be curious and ask specifically why, to understand why they would be saying that's important for you. There aren't really blanket bans on vigorous exercise used to be a very cautionary tale for pregnant women. Those don't account for individual fitness or pregnancy related cardiovascular changes or training history. So those aren't really supported by evidence any longer. The current approach is much more nuanced and more respectful of individual bodies, effort, and context. Having had two children myself, I just really want to validate anything that you hear in a lot of education with women's health was fear-based. Like, do this and you'll harm your baby. Do this and you'll hurt yourself. So I appreciate that even if it's not true, the consideration that it could be is scary enough to dissuade people from doing something or not doing something. Most of the biggest ones, the heart rate cap was one that I had to work around a lot a decade ago. And nowadays, I think women are much more quick to appreciate, they might know what's best for their body going into a pregnancy. Some of my work is listening to and validating the real fears and concerns, and then not taking a fear-based approach to training and nutrition in pregnancy. Let's make evidence-informed decisions. Let's understand why that's scary for you. Let's understand why this could be true or not true in your case. The plural of anecdote is not fact. And just because somebody heard something in a forum online, it's valid they are scared. It is valid they want to talk about it. It's valid that they would also make decisions based on what's right for them. Sometimes that's not even in the literature. So we're doing the best we can to make informed decisions. Certainly, and there's degrees of, concern when it comes to gestational diabetes. There are things underneath that, like impaired glucose intolerance. Sometimes this is within a woman's control because of lifestyle choices, and sometimes it's less within a woman's control, especially as women are having babies in their late 30s and early 40s. So some of these physiological effects that we're seeing with the impaired glucose or gestational diabetes are potentiated more depending on lifestyle and age and hereditary disposition. So there's a lot of things to consider when it comes to getting down to specific advice. I kind of take a big picture. First, I want to understand if it's an official diagnosis, how they're feeling about it. And, a lot of the times the way that diagnosis is received is they do the oral glucose tolerance test. Then they have to go back and do a second oral glucose tolerance test. And then they get a note from their doctor or a phone call that says, yeah, you have gestational diabetes and here we go. It can be kind of like an abrupt and high friction experience, especially for women who are trying so hard. So when I get clients that are in that space, a lot of the work is just around again, not fear-based education, meal timing, making sure that if we're going to have fruit, like a high sugar fruit, like a, mango. I'm thinking of a client I had who really loved frozen mango, and She got impaired glucose measurement during her pregnancy. So for her, it was like, let's incorporate a bit more fiber. Let's make sure that we're, kind of partnering that higher sugar intake with something that is going to slow the sugar distribution into the bloodstream. And this is where complex carbohydrates are really valuable, especially for clients who are athletic and running throughout their pregnancy. So it is a little bit of a dance if, a client is getting a diagnosis like that, is continuing to be very active and needs to be mindful of their nutrition. And so how all those pieces work together, it depends on the nuance of the individual. I think the broadest guideline that I see is, having it for postpartum clients is, like having the all clear from their doctor. Like this is where integrative medicine and conventional medicine like hold hands in the best way because, I'm really looking at the experts of that client, like their healthcare team, to give them the confidence that everything's going great. So I think that is often 6 weeks for a lot of clients. And then when they have, hit that point, then it's a question of like, first of all, does the client want to get back out and run? Because like, it's not for me to suggest like, okay, you've hit this mark and now it's time to start again. And then a lot of the times with clients postpartum, I'll see like, bleeding is one thing to pay attention to. Like if you go out and do, let's do a walk, let's do a jog, let's do a lower pace thing. Again, running is high impact and that can be very physically jostling for a body that's still healing. Did they have a C-section? They might need 8 weeks before they get the all clear. And if they got a C-section, then we need to be careful about what kind of training that we're doing that isn't going to exacerbate the abdomen healing. Did they have diastasis recti in their pregnancy, that abdomen separation? And if so, then there's very specific exercises that are contraindicated for that type of healing. So we don't want those clients to be doing things. And sometimes that's running that's going to exacerbate the ability for that to heal properly. In those cases, and diastasis recti is fairly common, what's the degree of separation, and then what kind of cross training, if they are interested in going back to running, what kind of cross training can we do to ensure that we're encouraging the right healing and not further aggravating that separation. And there's so many good programs online that can support that as well. This is the beauty of that RPE. It's like I felt very confident that I made a lot of adjustments, right? I wasn't doing vigorous running. I made a lot of adjustments throughout my pregnancy, but I did strength training and aerobic training all the way through up until my due date. And I felt just fine. That's my journey. I work with people who don't train throughout their whole pregnancy because they don't want to, or they don't feel good, or it doesn't feel right. So there's so many reasons why this is very much a client-led decision. And I think this is sometimes the shift that gets missed because there isn't and shouldn't be any broad guidelines saying like stop working out at X period, because that I think ignores the very real individual decision-making power that a woman has at this time. So there's no objective right answer. There is an answer that is right for the client. And so some of my work is just me being curious and then also encouraging tolerance and curiosity for the client experience, like teaching them, it makes sense. You'd be very frustrated if you were able to run and now you're pregnant and you don't feel as able to run. So it's really like, how can we create that tolerance for the change that's occurred?